Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Information Technology Committee. Today's meeting is officially called to order. Next on the agenda, I would like to have a motion to approve the minutes of Information Technology Committee meeting held on June 13, 2022. Any seconds?
Second.
Yes, thank you. Does any committee member has any question concerning the minutes? No? So I will take a poll of all the committee members. Jose Pagan?
Yes.
Dr. Katz?
Yes.
I also vote yes. Thank you. The minutes are adopted. Next, we will have the CIO report. Kim?
Thank you, Mr. Chairman. Kim Mendez here, Senior Vice President, CIO for New York City Health and Hospital. And I'm joined today, starting on my left, with Shoma Badori, who's our Chief Information Security Officer. Next to her is Apoorva Carrier, who's our AVP for Finance and Administration. Immediately to my left is Jeff Lutz, our Chief Technology Officer, who will be working on our technology issues right after our meeting here. And I'm also joined by Dr. Michael Boughton, our Chief Medical Information Officer. Thank you. We have our agenda here. We'd like to, provide some general updates. Our focus today will be on our data center migration. We have some really good feedback and some updates there, as well as we'll highlight some key clinical informatics and application areas. And I'll close with an overview of some of our acknowledgments for our staff work. We can go to the next slide. I've included this slide. This is an alignment of our New York City Health and Hospital Technology Department 2022 goals. I will not read through all of them, but you can see that highlighted to the right of each one of the different 5 categories is the alignment with our mission and vision of the organization. We can go to the next slide. And here we'll start with our data center migration. Just reminding everybody, our data center is actually a 2-year project. It is the migration from our 2 data centers who were at end of life to 2 new data centers. Our first one is going from SunGard over to QTS. The overall project, which started in May of 2021, with the inline for both of them to be on board by May of 2023. We are currently 63% complete on the overall project, meaning the 2 data center migrations. However, we are over 90% complete on our first transition from SunGard over to QTS. And just wanted to pause there and recognize all of our staff members who have been working diligently to meet that expectation. And we will be transitioning out of SunGard by the beginning of October. We actually had work this weekend that was done by Metro Plus and having some moves, and we have completed all of the 13, what we call move waves. That was completed by August the 9th, 2022. And currently Epic is running over at our QTS, which started in July. We've also improved some of our internet redundancy and some capacity in the month of August. And our focus today will actually be on some of those enhancements of our process and some new technology that we'll be able to take advantage of at the new data centers. We can go to the next slide. This is a visual of what I just reported. It gives the overall timelines and how we're tracking to that, and we remain on target and on budget for the overall project. Thank you. One of our focus in EITS is our ongoing continuous quality improvement to have a reliable and a secure environment, looking at enhancing our processes from specifically around some of the operational areas, and ensuring that we keep ourselves abreast of best practices in this area. We will be moving forward with leveraging our Cisco vendor resources as a component of our change management review. Anytime we have a change within our system, we have a detailed process so that we are able to have all the stakeholders involved and to ensure that we evaluate the change itself, any interfacing that might need to be done, the training of staff, and implementing that. Also, part of our CQI is the augment of failover capabilities for the data center and the local facility main distribution framework capabilities. In addition to that is our review of critical infrastructure and a refresh as we move each time of the configuration of our environment. And of course, the deployment of our future technology and leveraging our new data centers, which I'm going to turn over to Jeff. At this point, we can move to the next slide, and we'll have an overview of like 4 key areas of future technology that we're taking advantage of some of those now.
Yes, thank you, Kim, and good morning, all. So what you see on this slide reviews, as Kim had mentioned, some areas that we're able to now with putting in some new equipment as well as with our partnerships with our vendors to really help to improve the environment, both from a performance and a resiliency perspective as we move into these new data centers. And at the same point, we can leverage not only in the data centers the same technology, but we can also leverage it at our facility level as well. So also similarly improving the experience there for our end users and patients alike. And each of these, so the first one talks about our ACI configuration, which basically talks about an application-centric infrastructure. And this one is truly built for within the data center. It allows us to do some basically what they call segmenting and to prioritize traffic as well as break the traffic for each of the applications into smaller groups. That way, if something is affected for one, it doesn't affect everybody else that's there. The next two, between the Nexus dashboard and the DNA center, as well, is the ability now to, we have, as you can imagine, thousands upon thousands of these devices that are out there. So anytime we need to make a change, previously, it involved a lot of manual effort, having to visit these and touch it, and would also be interruptions, and then potentially human error involved inside of there as you're pushing updates or making configuration changes. What this allows us to do now is, from a central perspective, look at these changes and push those changes out in a controlled fashion, as well as reboots, restarts of these devices, and ensure that we're doing this consistently across the environment, as well as give us a better holistic view of the environment. Much like we do with the desktops today, we can control when these are pushed, as well as when they're updated and started. And the final one is what they call software-defined access. So that allows us now, as well as from the application, but then from now the end user, so say take things like biomedical devices or other devices that are on there, we can look at and say, and prioritize where their traffic is going so that they're talking to their applications much quicker and again, in a much more stable fashion, and give us the visibility to see if there's any interruption or issues with those devices specifically, and then thus responding to that or again, improving those performances. So these are some of the new things that we're able to take advantage of, not only within the data center, but as we build that out there, then we can similarly spread that to our end locations.
Thank you, Jeff. Chairman, I'm going to just pause here for a moment, and then we'll move into clinical applications and informatics.
Okay, let me poll the members to see if they have any questions. Jose, any questions?
No questions, thanks.
Dr. Katz?
Questions, thank you.
Okay. I just have a question. If you go back to the slide of the network, the future technology, are these deployment for this technology enabled because of the data migration, or they are independent? So that means that, are we going to be able to use this technology even during the time of the migration, or we will make use when the data migration is complete?
Great question. So for it, we're able to use it today, and the only place that didn't have it, because we were moving out of there very quickly, was within SunGard.
Right.
But similarly, we have actually made those changes within Jacoby, but the new data centers will also have them, and we are actually making these changes as well at each of the facilities. I know Kings and Bellevue, for example, already have elements of these pushed out to there, as well as Coney Island with their new building and everything will have all of these. So we are rolling this out enterprise wide as well.
Okay. And will this technology be able to also allow you to deploy any upgrades to the instrument that are connected? I know that in the past we have had some presentations about different machines that were connected. And will these tools allow you to deploy any security fix or whatever you need to deploy to those machines, or this only refer to actual PC computers in desktops and
Yeah.
servers?
So this technology right here only applies to our network infrastructure as well as our voice infrastructure on the back end. So all of the network gear, the switches, the routers, our firewalls, as well as the access points, as well as our phones that are currently using voice over IP, WebEx, and the like. Those are what's managed and pushed through these services. It would not unfortunately touch the biomed instruments, for example. It could help to highlight and show where they are, and that's what the security technology leverages some of this technology for it, as well as allows us to place it into more of a singular view in a bucket for them, so they know everything that's connecting to is connecting into one place, as opposed to today where they could connect to multiple. Um, so it's only our network infrastructure as well as our voice, which is also being run through Cisco, is where this is managed.
Okay. Are we working, or do we feel that is a need to look at how to deploy more centralized to those equipment, or do you think that the current infrastructure that we have is good enough for what we are doing with those equipment?
Yeah, I'm going to ask, that's an excellent question. So Shoma, actually our chief security officer, we have some applications already in play. You want to speak to that, Shoma?
Sure. So thank you very much. So basically, we have, as part of our layered defense, it's several security products that are already rolled out to the enterprise to protect from cybersecurity incidents. Specifically, with biomedical, we have an inventory tool that assesses the risk level for all of our biomed devices that has been deployed and in place for the last year. So that's something that we continue to work with as part of our layered defense. And the other portion that Jeff just mentioned, these new technologies also help with segmentation as well. So in the event of a cybersecurity incident, we can segment off particular devices if they are affected. I hope that helps.
Yeah, that helps. I think from the security perspective, that definitely helps. And I would love to learn a little bit more. Maybe can be something that can be set up for me to learn a little bit more.
Sure.
I don't know if Jose also would like to. But I was actually talking about something a little bit less challenging. Is like all those equipment will require some software upgrades.
Oh,
Yeah,
yeah.
Because of technology changes and functionalities. Are those deployed kind of centrally, or you have to go machine by machine to do this?
Right.
Oh, no, exactly. And that, at least for this, that's any of the technology that we're rolling out these days, to your point, it is centrally managed, so that we don't have to go and touch them to individually and configure. And it's definitely the trend of the industry. And like I said, not only does it give us the ability to centrally manage it, but you get all the other bonuses along with that, right? Now it's a consistent environment. We can push the changes quicker. And we actually have a tight, in this case, and it's a model we're looking at for a lot of our other critical infrastructure, but with Cisco, we have a very tight partnership where they'll actually help to look at the configurations with us and review best practices before we push anything, so we can identify issues ahead of time, or in the event that we do find those issues, we can either roll them back or work with them very quickly to address. So yes, so that's exactly what we're pushing out, and that was a big piece of this network environment that we've been working with Cisco on to ensure, like I said, across every location, including the clinics. So.
Thank you. I don't want to take any more time with this, but I would love to learn a little bit more about this when you have time and colleagues are able to set it up. Thank you, Kim. Should we go to the next phase?
Yes, we can move to the next slide, and we will turn over to Dr. Michael Boughton. Here we're going to we're going to kick off with an overview of two key areas from Care Experience, which is our newly implemented Palm Vein, as well as the MyChart activation. We'll give an update there across our system, and then our recently recertified Gold Star from Epic.
Great. Thank you so much, Kim. Yeah.
Go to the next slide.
Great.
Yep.
So this is a little busier slide than usual, and I'm going to jump into some of the details of our MyChart activation rate. Right now, we're sitting at 68% of all comers that have come to our center in the last year are activated with MyChart. Nationally, this puts us in the top 25%. The Epic average is 53. When you compare us against other safety net hospitals, that average is 46%. So we're doing quite well. That said, on the I think it's to the right side of your screen, so the darker blue color, you see we have heterogeneity in our site-by-site activation rate. And the reason I'm showing you the slide on the left is that depending on how you cut the data, it just frankly looks different. And what I mean by this is the following. When you look at the darker screen, I think it's Harlem and Woodhull are towards the bottom of the list. But when you slice that data and say, okay, of the patients that have a primary care doctor at our institution, how are they doing? And you can see those two sites do actually much better when you're only looking at that patient population. The reason that I've historically given the other chart, the darker blue one, is that is not manipulated data at all, right? We haven't done anything yet. There's no post-processing of it. And it's easier to benchmark where we are compared to where other institutions are. The data on the left, we use on a site-by-site basis to say, you know, Harlem, how are you doing? What could you improve with your patients that are in primary care? And what should be the site-specific performance improvement initiatives at that site? So we have a MyChart steering committee centrally, and then we also have local at each facility MyChart steering committees. And those local steering committees choose site-specific PI projects, and they might target your activation of MyChart with primary care patients. And another site might very reasonably target something like logins per user, which is data I've shown you before. Frankly, I think long-term, I think it's useful to show all of the information and to cut it differently. I think the takeaway, I think, is the following, though. Our activation rate nationally is very, very strong, and our logins per user is not as strong, and it's an area that we need to push on and improve. And the way we do that is we add more functionality for our patients, and we respond to them quicker when they talk to us, when they message us through MyChart. So the darker blue one, I think, is the end state, like how we're doing overall. I kind of think of it in like the from a physician perspective, I kind of think of it as like the hard outcome here. It's the patient-centered outcome, but then all the other ones are kind of the process points that go into feeding that. I'm happy. I know I just went through that a fair amount. There's a good amount of data on this slide. So is there any questions on this one?
I'd just like to add a point on the dark blue slide that what's integrated there from the overall in the facilities that are not just the Gotham sites or ambulatory is the data also includes the emergency department and the inpatient population, in addition to if they have ambulatory there. And so the chart on the left is purely our ambulatory facilities looking against each other. It's like an apples to apples, correlation or overview there, comparison.
Yeah, fair. Thank you.
Thank you, Dr. Bolden. Really great addition to the chart and provides a better picture of what is happening. But let me ask the board members if they have any questions. Jose, any questions?
No, no questions.
Dr. Katz?
No questions, thank you.
Dr. Bolden, I only have a suggestion. Again, thank you for the data. This is very, very illustrative. If we could sort them by the activation, like you do in the dark blue, because I was trying to look at the ones, and I would like to highlight Lincoln. It's around 90% on primary care, while it is 63%. I think it may have to do a lot from the number of patients that they see in the ED. I don't know, but that looks like a conclusion. And also, but they have also a lot of people. They are like maybe the fourth in terms of number, because I think Elmhurst is the largest number with 33,000, then followed by Queens, and then I think Lincoln. So I think that, that is very impressive when you're talking about the primary care. So thank you for sharing this data, and if you can sort it then by activation, that would be great. Thank you.
Yeah, thank you. I did think of that after this had gotten submitted to you. So I've already working on that change, and we'll put it in an order that's more easily findable. All right, you can go to the next slide. So what I'm going to talk about here is biometric authentication, identification of our patients. We have been rolling out, and we are now live at 4 of our acute care facilities with palm vein authentication. Basically what this is that we ask the patient for their date of birth. They put down their palm. The first time they actually need to touch the device. All subsequent times they can actually just hover their palm over the device and it will read their palm and we can quickly and incredibly accurately identify the patient. When I say incredibly accurately, what I mean is in combination with date of birth, it's 6 sigma. And for the emergency department or in a setting where the patient is unconscious and unable to provide that information or unable to provide any other external information, it's going to make a mistake and properly identify the patient once out of every more than 1 million times. So it is a faster process and it is a far more accurate process, which will help us reduce our duplication rate, which is the number of patients that have more than one chart in our facility. You can see this is a week by week. The graphic here you're looking at is a week by week trend of the purple line is the biggest one to pay attention to, which is our utilization percentage. Those are Elmhurst and Woodhull are the first 2 that have a higher utilization rate, and they have continued to have a higher utilization rate. They've done a great job, but I think one of the reasons they've done such a great job is that those are the 2 sites that went live, that used it as our proof of concept. So those both had several months of experience with this before our other sites. Our long-term goal when we wrap up this project in February is going to be to have everyone be at 75%. I don't think that's a reasonable short-term expectation for everybody. And what I'll tell you is within each of those, within each site, there's heterogeneity, but then within sites, there's heterogeneity as well. And what we're doing with our ambulatory care colleagues, and it's primarily ambulatory care, this is in the ED as well, but it's primarily ambulatory care where the variation is we're talking to the departments that aren't using it as much because a lot of departments are using it. Overall, I firmly believe this is going to be a time-saving thing for our end user clerks, and I think it's going to improve our system and really the safety of our system, because knowing who the patient is the way you know what their past medical history are, what their allergies are, and allows us to provide better care. Okay, you can go to the next slide.
Can I ask you a quick question on that?
Please.
Fenioski, can I ask a question on that?
Yes, please.
So when I go in and I put my hand down, then somebody tells me, "Welcome, Jose, to your appointment." And how does that work? I'm trying to understand the process.
Vinny, do you mind if I can I take a stab at this first and then you can go with me? So you first have to register. You come in, you register the first time, you put your palm vein down. It securely attaches to who the patient is. And then the next time you come in, you just put your palm down, put in your date of birth, and it says, welcome, Jose.
Okay, but I guess what I'm trying to understand is are we losing the human interaction that happens when you go to an appointment? And I mean, why is it so much better, I guess?
Yeah. So we still have registration clerks. The majority of our portals of entry, we also do have kiosks where this is being rolled out. But kiosks were a separate project that this is dovetailing nicely with. We still have registration staff. So there's still that face-to-face communication. There's still the patients are still signing their TPO document. They're still having a conversation with the clerk. It is the identification of the patient to make sure that this is the same Jose Pagan.
One thing that we don't always think about is while person to person is great, sometimes our patients object to the possibility that other people are hearing the answers to these questions. I have one patient in particular that I'm thinking of, and one of the reasons I like this system is that when he comes in, he would just put his palm out, as opposed to answering a lot of identification questions, which he's uncomfortable answering. So it can be in many ways a more private interaction.
Got it. Thank you so much for the clarification. Thanks.
And I would like to add, I have used this system, and what I find is that for a straightforward registration, it allows you to do what you need to do and move it and leave the clerks to handle questions and complexity. So in that case, you don't waiting in line when somebody's asking a question. So I think that it adds like simplicity, efficiency, and I agree with Dr. Katz, also privacy. So I really like the tool. Okay, any other questions? No, Dr. Baldwin?
Great, thank you. So the next slide is on our gold stars, which is basically an Epic program that says of all the features that Epic has turned on that they find highly effective and that other institutions across the country have found highly effective, how many do we have on at this point? And what the level 8 that you're seeing here, that puts us in the top third nationally of respondents. And you can see exactly where on the distribution we fall on the far left. What this is showing you is that we're doing a pretty good job of turning on features as they come out. Now, every time Epic does upgrades every quarter they're coming out with new features. And so we're always going to drop down as we address those and as we add in those new features. But at the end state of this is because we're staying on top of new feature adoption and because we are improving our current features, our system keeps getting better and better, and we keep pace with the other national leaders in this. At a future meeting, I'll share with you the other customers that are at level 8 gold stars, but it's, you know, it's some of the best places in the country that are there from an informatics perspective. And ultimately, the real benefit here is that our providers and our nurses and everyone else gets a better, more functional system, and our patients get better care. So these are really not IT settings. These are things that doctors can use to take better care of their patients. You know, the one that kind of comes to mind for me right now is we're working on right now something called ED Course. Instead of writing a progress note, I can just quickly type something on the bottom of my screen and it pops in and auto-populates my note. Now that's not on yet, but that's going to come in next, and it's probably going to save me like 15 seconds if I try to write it instead of writing a progress note. So it's a nice feature, and it's things like that that we just continually move our system in a better direction. All right, go to the next slide. We're continuing to expand the number of Epic modules that we use. So previously, we used another vendor for our dentists, and we have now moved them to Wisdom. Every time that Epic names anything, they make sure to give it a cutesy name, and this one is Wisdom for Wisdom Teeth for the dental module. And we have, once again, we have really good adoption of this. Now we've turned off at half of our sites. We are now live with Epic Wisdom for our dental clinics. We have really good utilization. You can see the numbers here on the number of completed visits. And behind those numbers, what we track is how long providers are taking in their notes, how long they're staying in their in-basket. And on all those metrics, we're in the interquartile range. In a lot of places, we're already above average, which for right after our go live, which was July, I think is pretty good. Similarly to that is the next slide, which is the Epic Willow module, which, and you might wonder where Willow came from, but I think Kim corrected me, or Kim knew this last time. Willow was a medicinal plant, is that right?
Right, that's what I was told, that, you know,
Yeah.
at some point it was used, has some medicinal component
Right.
to it.
So I guess that's why the Willow ambulatory module for pharmacy has that name. And what this allows, most of the features really just improve things for pharmacy. It improves our pharmacy billing. You can see on that top line of the metrics that our fill time, how long our patients have to wait, has steadily decreased since we went live with this, which is a real benefit. I got to tell you, as the end user from an emergency perspective, what the main benefit to me and our patients is I can more easily see what's in our pharmacy available to prescribe for our patients. And if there is an issue with the prescription, or, you know, I send something over that's not quite right, this pharmacist and I can have a more direct interaction. So there's benefits inherently to the pharmacy, and also really looping the pharmacy closer into our clinical fold, which is, you know, a big win for us as a system. And I think I'm going to hand it back to you, Kim.
Thank you.
I'm sorry, any questions on anything I just covered?
Jose, any questions?
No questions.
Dr. Katz?
No questions.
I just have a comment saying, like, I really appreciate how you are ensuring that the technology is to the service of our patients, not just for technology's sake. Because if you look at the gold star, it
Yeah.
may indicate that this is a way for them to encourage more of the use of the technology because you're competing on features, but I
Yeah.
think you're focusing on what is important to your patients. And I think that's very important. And I really like the deployment of Wisdom and Willow.
Yeah.
Interesting names. Thank you, Dr. Button.
Thank you.
Going back to you.
Thank you. We can move to the next slide. And I will just say, one of the components there is for the gold star is that we did look for a metric that was a national metric. Because one of our goals that align with the mission and vision is the usability, of our electronic health record. And we felt that this, and Dr. Boughton has been championing that with great spirit.
I guess the one thing I'd add in is that when we set our goal as a level 8, we didn't say we want to be level 8 first, because there's also a level 9 and there's a level 10. We looked at the features and said, what are the features that are going to be valuable to us, and then set our goal. Right? It wasn't the other way around. It wasn't the number first. It was the features, which is, I think, it's keeping our patients and our staff at the center of this.
Right, and bringing our councils together to make those decisions. So I am going to close with some acknowledgments of our team, just briefly. One is we can move to the next slide, please, is our application learning team. And this used to be the EPIC training team, and we've actually expanded their title as they've transitioned from a strictly implementation across our system to a more sustainable model for all new staff members who are coming on. In addition to that, they were critical to onboarding our supplemental staff in response to COVID-19. But also, they have added new services and training. We call it the Thrive program. So, we can keep things moving and continual ongoing learning experience. One such program is we've supported with Hillary Jalon as the Joint Commission Readiness, so that individuals are having right at their fingertips some training so that they are able to easily navigate through EPIC. They know where to go, how to go, and that makes that survey experience a lot more pleasant. That's just one example. Also, they support during our upgrades and any new applications such as Wisdom and Willow that we are moving out. And then you can see at the bottom, they're not just EPIC. We have actually transitioned them to our learning team to help with some of our other clinical applications. One is the Dragon system, which is the physician dictation or provider dictation, all the way up to Omnicell, which will be coming out in 2023, which is our medication administration initiative. So overall, you can see they've trained over 20,800 end users in 3,000 plus classes. We can go to the next slide, highlighting our amazing PMO or project management office team. There is a link there that outlines all of the work that they've done. But in short, I will say in EITS, we take in over 2,000 IT-related projects every year, and that has been sustained over the last couple of years. More happening from an optimization perspective with vaccinations, et cetera, in the last year or so. But these are small projects or projects that may be very large in scope that take 1 to 2 years to move forward. So excellent team supporting. And then I just wanted to say, you probably might have noticed that our Chief Application Officer, who is Sean Koenig, was not here today. And it is because we had to say farewell and thank you to Sean as he transitioned to a new position outside of New York City Health and Hospital, and relocated. So we have an interim stabilization plan, which is moving quite well, and we wish Sean very well. And I will close just by saying that on the 21st of this month is National IT Professional Day, and I just want to thank my entire team here at New York City Health and Hospital, and I'll close there.
Thank you, Kim. We really appreciate your presentation, and I would like to ask the members if there is any question. Jose?
Thanks, and thank you so much for the update.
Dr. Katz?
No, thank you for the update as well.
Again, I also want to echo Dr. Katz and Jose's comments. Thank you for the day. I always appreciate how you always connect your activities to the strategic plan and the pillars and the values that are very important to the system. And the excitement in which you present technology. I think that I appreciate Dr. Bolton, really excited about the work that they're doing in everyone. So thank you so much. I wanted to ask if there is any old business that we have to address. Any new business? Well, being no further discussion, I would like to adjourn this meeting. Thank you, everybody. And we got 60 minutes back to our
Penny
live.
should run all meetings going forward.